Hello and welcome to today's webinar for mental health professionals. It Works, But How? Examination of Mechanisms of Change in PTSD Treatment, featuring Dr. Sheila Rauch. My name is Astrid Masfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. You will have the opportunity to submit any questions by typing them into the chat box located on the control panel. You may send in your questions at any time, and the presenter will address them during the Q&A session at the end. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation, and the link to the webinar evaluation will be sent to each participant within 48 hours of this webinar. The post-test assessment will occur at the end of the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Sheila Rauch. Dr. Sheila Rauch is an associate professor in psychiatry in the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine. She serves as the clinical director of the Emory University Veterans Program and director of mental health research and program evaluation at the Atlanta VA healthcare system. Dr. Rauch has been conducting research and providing PTSD and anxiety disorders treatment for over 20 years. Her research focuses on examination of mechanisms involved in the development and treatment of PTSD and improving access to effective interventions. She holds a diploma in cognitive and behavioral psychology. In 2017, she was awarded the Outstanding Mentor Award from the Emory University School of Medicine. She served on the VA DoD PTSD Clinical Practice Guideline Committee in 2010 and 2015. She is a fellow of the Association of Behavioral and Cognitive Therapy and a member of the Board of Directors and Scientific Council at the Anxiety and Depression Association of America. I will now pass the screen to our presenter. There will be a brief pause while I do so.
Hey everybody, can people hear me okay?
Yes, I can hear you.
Great. So thank you and welcome. Thank you for being here. Show my screen. I'm really excited to be presenting this webinar today for ADAA, and I'm hoping we're going to have a lot of good discussion and at the end, some good questions. Now I'm hoping to not have to look at my face while I'm doing this whole talk. All right, so today I'm going to be talking really about It Works, But How? Examination of Mechanisms of Change in PTSD Treatment. And I'm currently at the, as was just mentioned, Emory University in the Emory Veterans Program and at the Atlanta VA as the Director of Mental Health Research and Program Evaluation. The next slide is a bunch of funding that I've gotten that's represented in the different slides that I'll talk about. Basically, this is my VA Career Development Award, a large translational treatment outcomes trial, and some other research. And then I also received some money for books that I'm author on as well. So first of all, we know a lot about PTSD treatment research. There's lots of research supporting that we have effective therapies out there, specifically prolonged exposure, cognitive processing therapy, and eye movement desensitization and reprocessing all have a reasonable chunk of evidence supporting their efficacy. PE and CPT have really the largest amount of clinical trials supporting their efficacy and effectiveness. In addition, we know there are a couple of SSRIs that have also shown effectiveness, including paroxetine and sertraline. But even though we have these great treatments, access remains a significant issue for a large majority, actually, of people who have PTSD. the modal response for someone with PTSD is to never access treatment in their lifetime. One reason for this is that PTSD is a disorder of avoidance. And so people with PTSD tend to avoid everything related to their trauma, and that includes treatment. Going in to tell someone about what they've experienced is probably not something most people with PTSD are going to do naturally. In addition to that, even if they decide to seek treatment, there's significant stigma regarding treatment and regarding the mental health diagnosis. There are also barriers to care, including things like access to people who know the effective therapies or effective medication management strategies. Especially if you move outside of the VA or the DoD system, there are very few community providers who are well-trained in prolonged exposure or cognitive processing therapy. And if you find that golden unicorn out there that is trained in one of those and you have PTSD and you're ready for treatment, oftentimes mental health coverage through insurance isn't adequate to receive a full course of therapy. And then on top of all that, some people don't get better. They partially respond to a full course of treatment, or they don't complete that treatment even when they finally get there to those resources. So what do we need to know as a field to improve treatment access and outcomes for PTSD? One thing we need to know is why and how effective treatments work. That's mechanisms. We need to figure out how to increase the speed, the efficiency, basically, of response, as well as the magnitude of response. How can we get more effective treatments and treatments that work more quickly? And that may be through augmentation, so taking the current treatments that we know work and adding to them, either for specific patients or overall. Or how can we just generally increase efficiency, so make that same treatment episode shorter, but have the same magnitude of response for patients. And then finally, developing novel treatments that address those people who may not respond at all to a given effective treatment that we have out there. So that's one thing we need to know is how, mechanisms. The second thing is how to increase reach and access, which is actually related to mechanisms in a lot of ways. Increasing reach and access oftentimes can refer to models that have getting those models of effective treatment out to new settings. So how do we get PE or CPT or some version of those into other non-mental health care settings, such as primary care? How do we get those treatments into intensive outpatient programs where patients can come from all over the country for a massed episode of care with experts in PE or CPT? Those are interesting ways to look at increasing reach and access. In addition, we've got things like telehealth, working on reducing stigma, and also getting the word out in social media that people with PTSD can get effective treatments. We have options for treatments that work, and you can and should be able to access them in your home communities. So we're going to start by talking about why and how effective treatments work. That's really going to be the focus of most of my talk today. I'll talk a little bit about access and how it's related to mechanisms, but focusing more squarely on mechanisms. So moving back to get more specific about efficacy of prolonged exposure, we know it's very effective. It is the treatment that has the most studies done on its effectiveness and efficacy. We know that it reduces PTSD, it reduces general anxiety, it reduces depression. It also reduces most other negative affects that's related to PTSD or connected to PTSD by the patient, including things like guilt, anger, a sense of moral injury. All of those things tend to be reduced at the same time as PTSD is reduced. Another real strength of prolonged exposure is that it's effective in a highly comorbid and complex patient population with PTSD. Up to date, prolonged exposure has been used with lots of complexly traumatized and complexly comorbid patient populations, including severe substance abuse, those that are homeless, SMI populations, people who have comorbid borderline personality disorder. And in all of those cases, PE has demonstrated effective response for the PTSD symptoms and oftentimes reductions in other general negative affects. In addition, the PE protocol is extremely flexible. It's very individualized to that patient that's sitting in front of you in the office. So that's another strength, and it's also another reason why it works so well with complex patients, that we can work with the PTSD as it's experienced in this individual. The components of PE include psychoeducation, imaginal exposure with processing, and in vivo exposure. So moving to treatment mechanisms, what is a treatment mechanism? Lots of times people will use that term for any kind of thing that correlates with treatment response, which isn't exactly correct. Mechanism implies a factor that causes or drives treatment change. It needs to be causal in order for it to really be a mechanism. There are lots of things. A good example of that is there are lots of things that change with PE. Depression, I've mentioned, guilt, but I wouldn't necessarily call depression or guilt a mechanism of PE. We would look more at other things that are actually, we think, are causing or changing the patient and pushing the symptoms down. That would be the mechanism. It's most likely that there are many mechanisms that work in any effective PTSD treatment. This includes PE, this includes CPT. It also, what I would also like to point out is that the mechanisms are likely the same in some treatments with variations. So it may be that there are several mechanisms going on that can help PTSD respond. And in PE, we've got 2 of them. In CPT, we've got 2 different ones, or one the same and one different. And then in SSRIs, we may have an entirely different mechanism. But that's the reason, one reason why examining mechanisms and looking for causal inference in our treatment studies is really important. So why study treatment mechanisms? There are lots of reasons to study treatment mechanisms. The most, well, I've got 6 of the ones that I think are most compelling. First of all, we have a lot of people doing a lot of different things in PTSD treatment research. And by focusing on mechanisms of change, it can help bring order and parsimony in our treatment decision-making and in treatment development. It helps us to be able to communicate with each other when we have 3 different exposure-based treatment protocols to see where are these the same, where can we use our evidence base from one treatment study to look at another treatment that may be a slight variation, and where do we need to have a second clinical trial to examine that question. In addition, it looks at mechanisms of change can help us look at impact beyond mental health to larger biological systems. There's lots of research suggesting that some of the mechanisms involved in PTSD treatment development may be the same as those involved in treatment response. In PTSD development are the same as those involved in treatment response. In addition, those same mechanisms are involved in other physical health issues, and there's a growing evidence to suggest things like cardiovascular health, inflammation, that they may have broader biological system impacts. And looking at mechanisms of change is one way to help us make those connections more effectively and more correct. It also is a way to optimize treatment outcomes. So looking at mechanisms, if we know the piece that makes this treatment work, then we can focus in when we're making decisions day to day and patient to patient, session to session, on how to make this specific mechanism work more efficiently or effectively for this specific patient. And then we can also take that to on a larger scale to systems and to program design and say, if we know inhibitory learning is a mechanism of change in PE, how do we optimize that as we're designing a program? If we know extinction is a mechanism in PE, how do we optimize that? And then that also can help us improve dissemination. Again, if we know how the treatment works, then when we're training people, we can pull away the stuff that's extra or that we can vary with your setting or with your patient and really focus in on when you're deciding how to work with this patient, you need to make sure the exposures are at least 30 minutes in duration. But we need to know the mechanism that we're focusing on to be able to make those more fine-tuned decisions. In addition, mechanism can help us match patients to treatment. So it may be a patient that a particular mechanism isn't as relevant for, and so we might match them with a slightly different treatment. We're not there yet at all in our field right now, but I would look for a future where we'd be able to do that. And then, of course, we always want to contribute to generalized knowledge and learn. We're all, or not all, I'm an academic. I like to know how things work. I'm curious, so that's always important. So informing, mechanisms inform, and this includes informing novel treatment development. So starting from the ground up, if we know how other treatments work, that might help us to figure out developing a novel treatment that's completely a different mechanism, or that same mechanism in a slightly different way. So that might include things like mindfulness-based exposure therapy that Tony King and I and Israel Lieberzahn worked on when I was in Ann Arbor, or it might include augmentive strategies for PE. There are lots of ideas and lots of ongoing preliminary studies right now looking at ways to make imaginal exposure specifically work more efficiently for patients with things like TMS or DCS or other cognitive enhancers like MDMA or THC or other things provided right before an imaginal exposure session to make the extinction retention more efficient over time, typically is what we're looking for. And then you can also inform modifications to effective treatment. So taking PE and breaking it down to its finest points so that we can provide it in way shorter sessions or in different settings like primary care, or potentially through providers who aren't mental health providers. Can we train paraprofessionals in the bones of exposure and help them either help with in vivos or help with imaginals in different ways? And then also looking at provision in new modes like telemental health, and how far can we bend PE before it's going to break, providing it in a new mode. So mechanisms of PTSD treatment specifically focused on prolonged exposure. We know a little bit theoretically about PE. So PE was developed out of emotional processing theory. And in general, when you're trained in PE, and what I'm doing PE, I'm using emotional processing theory as my guidebook for how to make decisions with any individual patient or any difficulty that's coming up in a session with a patient. In addition, there are other very relevant theories that have been developed over time that are also important to consider. It includes fear learning and extinction, and what we know about how those processes work in the brain and the body. Inhibitory learning from Michelle Krask's lab. Again, that's probably a piece of what's happening in exposures with patients, that we're developing inhibitory learning against those fear learning pathways. And then there are also neurocircuitry models of PTSD that are very relevant to PE. So what's happening in the brain when you develop PTSD, and then also looking at what's happening when we're treating people with PTSD, so we can see if it's those same systems that we're modifying, or if this might be an entirely new set of learning or processes that are going on top of altered brain from trauma. So far in PTSD treatment research, we have lots of mediators and moderators of outcome out there that have been proposed and supported in different treatment studies, but we don't have many. Actually, we only have one that I'm aware of that's demonstrated a timeline in order to have kind of the low bar to establish causation. And it's that timeline, being able to say that this is happening before the PTSD symptom change is happening. So it potentially, or we think, or we believe this is the driver of that PTSD symptom change. That timeline is often not there. So what mechanisms do we want to focus in on, specifically looking at PE, and how do we decide what mechanisms? First of all, when we're doing clinical trials research, which is where this needs to happen, We want to use measures with previous signal as much as possible. So these would be looking at those things that we have a correlation with and trying to get more time-sensitive models and time-sensitive measures built into clinical trials so we can look at what's changing first, what's changing second, and what's actually driving that PTSD change. So we need to look in and get the signal with that correlation between whatever our proposed mechanism is and the PTSD symptom change. And whatever that PTSD symptom change in treatment or natural recovery. So because a lot of evidence suggests that we're turning back on a natural recovery system in effective PTSD treatment. We also want to look at ways to maximize efficiency in data collection. So as I mentioned, we're building this into clinical trials research, and clinical trials are very labor intensive and patient burdensome. We often are collecting lots of information from patients and needing a lot out of them. So we need to be thoughtful about what mechanisms we're examining and whether those are things that patients are going to be able to routinely collect in a high cost and high data quality manner. So as much as we can focus in, at least initially, on low burden and high information yield measures, we're going to be able to get more information and better mechanisms research. We also want to make sure, related to that and related to patient burden, that we're not interfering with recruitment in the clinical trial. Because if we add mechanisms research in, and it means only a small portion of people with PTSD who are getting treatment actually are in the study, then we're not going to be able to generalize to the general population. So put another way, if, for instance, if I added microbiome to my study where someone has to collect very sensitive personal data, it may result in only a small portion of people doing that study, and then we don't know how that relates to people who wouldn't be willing to give us microbiome. All right, so in my research thus far and in my Career Development Award and Progress, we really focused in on emotion processing and regulation in an imaging task. So that was our high burden and lower frequency assessment. Perceived ability to manage negative affect is a very low burden because we're collecting it based on self-report measures, and there are multiple measures that may even get at that in a more sensitive way. But that's something you can collect regularly over time and get a lot of information. And HPA axis function is the other mechanism that I've looked at over time in several studies at this point. And that's relatively easily collected within those same emotion processing and regulation paradigms. So we're getting both the imaging and the saliva to be able to look at cortisol, DHEA, and DHEAS. So to date, the mechanism that actually has the most research supporting it as a mechanism of change in prolonged exposure, and the mechanism that is shown actually to be changing in time prior to our PTSD symptom change is cognitions. It's negative thoughts about the self, and specifically the sense of ability to handle negative affect. So this came out of emotional processing theory, where we have the idea of two unhelpful thoughts are related to the development and maintenance of PTSD. The thoughts of the world being completely dangerous and I'm completely incompetent to handle stress, my symptoms, I'm crazy, I'm out of control. Emotional processing theory proposes that repeated, prolonged confrontation of trauma-related stimuli without negative outcome can help reduce those emotional responses connected to the trauma, so the intensity of affect gets less over time, and they incorporate more helpful thoughts into thoughts about themselves and the world into their worldview and into their trauma memory. They disconfirm the idea that that negative affect is going to continue forever, disconfirm the idea that I can't handle when bad things happen, I can't handle when I think about my trauma, and those sorts of unhelpful thoughts that fuel PTSD. So increased sense of self-confidence, as I've been describing, that occurs as part of PE, and increased sense of control over negative affect leads to reduced avoidance. So as you feel better able to handle things, you do more things. It also leads to more spontaneous exposure and continued reduction in PTSD symptoms. So we're really looking at that increased sense of self-confidence as an engine or a mechanism that's driving change in PE. And we have research to support that. So there have been a couple of different studies that have shown, there have been a lot that have shown a correlation between those two things. And there have been a few that have shown actually that the changes in negative thoughts about the self are happening prior to the changes in PTSD within treatment and across prolonged exposure. In addition, we have a study that shows that looked at PE by itself and PE plus formal cognitive restructuring, and we found in that study that cognitive restructuring did not add to the magnitude of change in symptoms, in PTSD symptom reduction, or in magnitude of change in the specific cognitions of negative thoughts about the self and the world, and self-blame, actually. So what that tells us is those changes in cognitions are occurring with the exposure components of PE without necessarily needing additional other components or formal cognitive restructuring. So treatment change in self-perceptions, we know reductions in negative thoughts about the self and the world are associated with symptom improvements. Change in self-perception drives that change in PTSD and actually in depression in a couple of studies. And that's been shown in PE and also to a lesser extent in one study with sertraline out of Nora Feeney's group. They've demonstrated that same pattern of change. And I actually showed it in present-centered therapy as well. So we really believe that this is a mechanism that is likely a mechanism that's retained across PTSD treatments. It is the one mechanism that's actually shown that time change to suggest a low bar causative relationship. So moving on to another potential mechanistic area of research is looking at PTSD and the HPA axis. So the hypothalamic pituitary adrenal axis is, oftentimes people think about this as our stress system in the most general sense of the word and most general use of HPA axis. And what I would say is there's a lot of research that's been done on HPA axis in PTSD and in depression. And one thing we can say firmly and securely at this point is that it's a very complex system that's very sensitive to multiple factors. And especially given the fact that PTSD and depression tend to have opposing responses in the HPA axis, and both of those issues tend to be comorbid in over half the patients with PTSD, it's an understatement to say it's complex. And there's a lot of competing results within the area of HPA axis. But one thing we can say is that in general in PTSD, the HPA axis tends to be reactive to trauma stimuli, more reactive to trauma stimuli. And once that system is turned on, it has a harder time turning off. So that's called a negative feedback inhibition loop. And that tends to not be as efficient in turning off. So it's hard to turn on generally, and it's slow to turn off once it's turned on. So we do know that there's some disruption, and those citations actually support that negative feedback inhibition loop. We also know that normalization of the HPA axis has been associated with symptom improvement in at least one study, actually in two studies, because my CDA shows that as well. There's little research that's examined how HPA axis function changes over the course of treatment, and those studies that have been done have had equivocal results, partly because there's very important differences in methodology, including time of day, including length of trauma exposure, and other things that really seem to be salient to the HPA axis that will influence those results. So in my Career Development Award in the VA, we looked at patients assigned to prolonged exposure and present-centered therapy randomly, and looked at a couple of different mechanisms, the negative thoughts about the self and then this HPA axis. And we looked, again, we want to be able to look across time and have at least one measure within treatment so that we can establish that time relationship to potentially have causation. And then patients were retreated if they didn't respond within the first course of treatment. All the data that you're going to see is actually that initial course of treatment where they were randomly assigned to PE or CPT. I mean, PE or present-centered therapy. The rationale for those two treatments was actually that we wanted to know mechanisms that are related to exposure specifically, and not to all of the psychoeducation and support and talking with someone who knows a lot about PTSD and the issues that you're having, which is basically what the present-centered condition focused on, is psychoed and talking with someone who knows PTSD. It was OEF, OIF, combat PTSD of at least 3 months duration. We excluded people really if PTSD was not the primary issue of interest. So if they had imminent suicidality or unmedicated bipolar or substance dependence to the point that we were concerned about that needing to be treated first. And then we also added a couple things that would influence HPA axis. So if they were working night shift, we couldn't bring them in. If they were on a medication that works on the HPA axis system as well, then we weren't able to bring them in either. So in this study, to look at mechanisms, again, you remember I wanted relatively low burden repeated over time so that we're getting the full cohort of people who would seek PTSD treatment. So we kept our research assessments to 90 minutes, and that included a psychophys assessment. And during the psychophys assessment, we also collected saliva for cortisol awakening. So each morning of the research assessment, they would collect it, and then script-driven imagery. So that's a 1-minute trauma script personalized to their trauma, and then 45 minutes of rest, and then a neutral script. And then actually flip that. There was neutral and then the trauma. And finally, we also looked at a fear-potentiated startle paradigm and also collected saliva in each of 3 PE sessions or present-centered therapy sessions, session 3, 6, and 10, just to be able to see what's going on within the sessions and how that compares with the script-driven imagery paradigm that they did at pre-treatment, mid-treatment, and post-treatment. Our sample was 91% male. This was early on in the OEF-OIF conflicts, and most of the service members that were coming in at that point in Ann Arbor were men. Ann Arbor VA has a higher rate of Caucasian, so that's 83%. Other than that, it looks pretty much like what we see across VA for these patients. We have about a 60% comorbidity with depression, about 16% who are abusing alcohol. Keeping in mind if they met dependence criteria, they were not eligible. Substance abuse, the same thing. Most of them had not sought service connection at that point. We had 61% complete the study and 38% drop withdraw, or a good chunk of those actually were people who either didn't start the treatment or who early responded, which I'll show you in a bit. We got very large and effective response for both treatments, actually. PE and present-centered were both effective in this patient population, but you'll see here the rates of 50% response or more were significantly higher in PE than present-centered therapy. We had 47% of the patients in prolonged exposure who met that criteria on the CAPS, and only 14% in the present-centered therapy. Looking at our mechanisms, we started with the correlation of negative thoughts about the self, the world, and self-blame. And what you'll see here is replication of that finding that negative thoughts about the self are strongly correlated with change in PTSD. It's accounting for about half the variance in our CAPS change from pre to post is accounted for by negative thoughts about the self. The world is also significant, but a smaller correlation, and self-blame, again, was also significant, but a smaller correlation. Looking at our sample split by responders or non-responders, so these responders are people who had a 50% or more reduction in CAPS from pre to post. So I would call those actually high responders, because if you had a 30% reduction in CAPS, you would probably have noticeable clinical improvement from the patient perspective. But we wanted to really separate out our groups to look at response. So our 50% responders showed significant reductions in negative thoughts about the self. Another way to put that is that they had less reporting of a sense of not being able to handle negative affect over treatment, whereas the people who were non-responders or low responders, maybe a more appropriate term, didn't have any change actually in that same measure. So what we know from here is that responders have large reductions in PTSD related negative self-perceptions about the ability to handle negative affect, and those reductions in self-perceptions to handle negative affect are closely related to those reductions in PTSD symptoms. And from previous research, not this one, we actually saw that the change in self was happening prior to the change in PTSD symptoms. All right, so looking at the HPA axis, again, this is in my career development award study, and here we saw in the script-driven imagery paradigm, which is a good way to think about this is it's a 1-minute trauma script, so it's kind of like a titer test that someone gets to see if you're allergic to something. That's kind of what's happening here for our PTSD patients, is that they have a 1-minute snippet of their trauma script, and we see if their system responds to that or doesn't respond to that. So you'll see the line with the open circles. Those are patients who are non-responders at the end of treatment, so 50% or more, they have less than 50% reduction in CAPS. So they just continue a habituation curve for the duration of the script-driven imagery 45-minute paradigm. Whereas the patients with the filled-in circles are having a little bit of a bump. So you'll see at 30 minutes, they hear that 1-minute trauma script, and that's where their HPA axis system, their cortisol, turns on. But that system is slow to show up in your saliva. So it actually starts showing up at 30 minutes after that, and then we're seeing the start of a down curve there. So basically what we're seeing is that at 30 minutes post-trauma script, there's a significant discrimination between people who will be responders at post and non-responders. So this is a test that potentially, if we replicate this, could be done at pre to see who's most likely to relatively easily respond to PE and engage with the emotional content of their memory is what we think is happening here. Those patients who are very efficient at continuing to avoid when they're presented with that 1-minute script are the open ovals. The size of that bump that I just showed you is also correlated with the size, the amount of change in CAPS. So we know both that there's a discrimination between responders and non-responders at 30 minutes, and then the size of the bump is related to improvement in CAPS. So the more bump you get, the more reduction in CAPS that patient was likely to get. Finally, with the cortisol awakening response, again, I mentioned that the HPA axis is a complex system. So this is a different type of challenge to that system. So all of us, when we wake up in the morning, have a cortisol response where our HPA axis turns on, and that's one of the things that helps us wake up in the morning and orient to the world and get ready for our day. People with PTSD don't tend to have that. It tends to be very flat. And so that's what we found in our pretreatment population. What we see, though, at post is return of that bump in cortisol awakening response in the prolonged exposure group, but not in the present-centered therapy group. So that's an important and key difference, suggesting a potential mechanism that's specific to exposure and to exposure response that we're going to explore more fully. And basically, this would be an indication that something about a biological system is being changed with prolonged exposure and not changed with present-centered therapy. In addition, more complexity to the HPA axis system. So I mentioned that the brief test of a 1-minute trauma script, we want big responses to that. So we want someone whose emotional response to their trauma turns on relatively quickly for PE. But what we find when we do imaginal exposure, so this would be a big dose of going through their trauma script and going across sessions, what we find is the low responders are actually the ones that have the big response over time, and it's actually an increasing response over time for the low responders, whereas the high responders are having a response similarly across the sessions in their HPA axis to their trauma memory, which is very interesting, and it actually suggests that there might be within those low responders, they may be the people who are pushing down the memory and having a hard time connecting, and then they're not really connecting and having that HPA axis response until they're getting to the later sessions. So we need to explore this more, of course, and replicate. But we did find that responder status significantly predicted that slope, and that it accounted for about 6% of the variance. So keep in mind the correlation with when we put actually both the bump in the trauma script and the change in negative thoughts about the self in a regression. The regression, about half the variance in change in CAPS was accounted for by negative thoughts about the self and change in negative thoughts about the self. And the cortisol HPA system added like another 5 or 6% to that. So when we're talking about the contribution of each mechanism, it sounds like the negative thoughts about the self may be a much more robust mechanism over time. All right. So I'm wanting to make sure I'm okay on time, and I am. Okay. So thoughts and biology. HPA axis reactivity to trauma cues prior to treatment does predict response to PTSD treatment. Both changes in negative thoughts about the self and level of HPA reactivity to that trauma script uniquely predicted reductions in PTSD. That's that regression that I was mentioning previously. In addition, increased perceived ability to handle negative affect seems to be an important piece of this mechanism, and it may be directly reflecting changes in neurocircuitry, or in addition, we need to consider that it might be a general modulation of this HPA axis that in turn then modulates the brain circuitry. We need to look more closely at how those processes are unfolding over time. So we looked at the progress study. So my next step after my CDA was actually a larger clinical trial integrating mechanisms into the clinical trial itself. In that study, which recently came out in JAMA Psychiatry, we looked at enhanced medication management with sertraline, PE plus sertraline, and then PE plus a placebo. Patients were randomized to each of those 3 conditions, and then we looked at cortisol awakening response, emotion processing and regulation and imaging at pre and post-treatment, and also looked at cognitions over the treatment study. So this is kind of the overall study design. What I'm going to be focusing on now is looking at biological mechanisms and outcomes across those 3 conditions and considering whether negative thoughts about the self in the world change across those 3 conditions, whether that change is different across those 3 conditions, and how those thoughts are related to each other. We had 223 OEF, OIF combat vets, across 4 sites, including University Ann Arbor VA, San Diego VA, Ralph Johnson VA in Charleston, and Mass General. And we ran mixed models actually looking at change in PTCI over time and change in PTSD symptoms over time. And what we found actually was that, first of all, the main outcome looking across those 3 conditions, we found no significant difference in CAPS across the 3 conditions. They all 3 were effective with large changes actually across all 3 conditions. What's interesting, one thing to note here is the change that we found in the sertraline plus enhanced medication management was larger than any other PTSD treatment trial, I believe, to date. At least it was a very large sertraline effect. And part of that, I think, was based on the enhanced medication management really had a relationship with the medication provider that allowed patients to talk about side effects and potentially stay on the medication longer than they would in general clinical practice, where a lot of patients discontinue relatively quickly from those meds. So the good news here is that we have PE and sertraline are both effective, and both treatments, if we combine them, we actually don't see a significant additional augmentive benefit. When we looked across the 3 treatments looking at negative thoughts about the self, we actually found the same pattern. So most of the change in both negative cognitions and PTSD happened in the first 12 weeks, and there was no difference between conditions in the amount of change in negative thoughts about the self. When we looked specifically at the 3 subscales of the PTCI, so negative thoughts with the self, negative thoughts with the world, and self-blame, that same pattern was held across them, across the 3 subscales. Yeah, it didn't differ by arms, which was surprising to us. So this is, first of all, it's very early results. We're still looking more closely into what we found and into the cognition changes. Contrary to what we've previously seen, the perceived negative ability to handle negative affect actually wasn't predicting the PTSD change in the next session, suggesting there was significant change over time, but there was no relationship either way. PTSD wasn't driving cognitions, and cognitions didn't seem to be driving PTSD, which is different than what we've seen in other studies. One potential explanation of this is that we had a pill placebo. So everyone got a pill and a therapy, and that may have changed the mechanisms that were going on in therapy. If a patient was attributing their change to having a pill or to the pill, that may make them less likely to attribute it internally to themselves and to internal changes they were making. So conclusions, we have several mechanisms of change that show preliminary support across many studies. We need lots of replication studies, and we also need more studies that are looking at causative paradigms, either assigning people to different conditions to look at mechanisms or looking more closely over time at what's changing prior to symptom change. We need to look at how to modify treatments to enhance mechanisms, and there's a lot of research underway looking at that. I mentioned earlier different augmentation strategies with medications or TMS or DCS. There are paradigms that can show people who extinguish less quickly, so looking at extinction learning itself and trying to identify people who may be slower to learn in that specific type of learning, finding ways to augment with those patients. And then another possibility is doing that brief 1-minute trauma script and seeing who's most reactive, getting them into PE as quickly as possible, because that seems to be preferentially beneficial, and then taking the patients who don't have that response to a 1-minute script and either augmenting and doing PE or augmenting and doing it an alternate treatment, or just totally trying a new treatment with those patients. Finally, I wanted to mention that across all PTSD treatments, there are really high rates of drop. Dropout is really the biggest issue in PTSD treatment, I would say, right now. So finding ways to get treatments to patients where they want to receive treatment, whether that's in a brief protocol in primary care or in a massed program in an intensive outpatient program, or getting it telehealth into their home. I think that's really one way to move PTSD treatment research out to where people need it and get more people treated more effectively. So with that in mind, I want to mention Emory Healthcare Veterans Program that's sponsored by Wounded Warrior Project, and is a way for patients to have a 2-week intensive outpatient program. It's no cost to the post 9/11 service member to come, and we're getting outstanding outcomes that I didn't present today, but I can tell anyone about if you'd like to hear more. So thank you.
All right, thank you very much for that great presentation, Dr. Rauch. We will now be answering any questions from the audience. So as a reminder, you can submit your questions in the chat box and Dr. Rauch can answer them. So we'll give participants a minute to think of any questions.
No questions at all?
We have one question. I'm going to forward it to you.
Do you think that looking at self-perception as a mechanism will be compromised by the fact that cognition? Well, actually, that's a really good point. Yes, so that does change things a lot, since now it's a specific symptom of PTSD. The one thing I would say, though, is that we should still be pulling out more specifically negative, the self-perception of handling negative affect as a mechanism, because I think that is actually what's driving. So I don't know that our current measures are set up for doing that. We'd need to pull items out and refine them now that our DSM diagnosis includes a bunch of what used to be outside or related issues in PTSD and not PTSD itself. How long does it take to get cortisol results back? So that's all of these mechanisms, things that I mentioned, are actually things that aren't ready for clinical care use in the present day. So if we were doing, if we were going to create that 1-minute trauma script, you test it, and if they're above a certain criterion, you do PE. We're a little bit off from that. We would need to do more psychometric studies and actually get an assay that can easily be used clinically. There would be some research and development that needs to happen for that. But the first step in that is actually replicating it in a larger sample, potentially in an effectiveness sample. So that is underway in multiple different settings at present. Is there a cut score to determine who will and will not respond to PE based on the 1-minute exposure? So that actually, if we were going to use that clinically, we would need to do the psychometric study to develop that cut score in a much larger population. How can these findings help inform how best to keep individuals in treatment who may be at risk of dropping out early or non-responders? So there's a couple of ideas that I have for how these results can help people stay in treatment. So one thing is, one way to help people stay in treatment is to get them to the effective pieces of treatment as quickly as possible. So moving people, not doing preparatory treatments, not expecting someone to be ready for PE, basically making sure as therapists and programs we're identifying PTSD in a patient that wants treatment and moving right to the most effective intervention that we can find for them, whether that's PE or CPT. So that would be one suggestion. In addition, it would be making sure that we're talking with our patients about avoidance and how avoidance tends to sneak in at any given time, and having that a piece of the conversation in every session so that we're retaining patients more effectively. Okay, what instruments were used to capture negative thoughts? That was the PTCI. In everything that I showed, it was the post-traumatic cognitions inventory. That's, I think, FOA et al. 99 is the primary paper for that. I think we can, we actually have moved a bit now as a field that we can look at more refined measures. I think of negative self-perceptions as being shame. Are future interventions going to pull from treatments to reduce shame, such as, so shame actually is self-blame, which on the PTCI includes items that focus on shame. It has been looked at as well in most of the studies that I've looked at, and it's less consistent whether that's a driver. What I would say, though, is that shame responds very robustly to both prolonged exposure and cognitive processing therapy. So I don't know that we need to jump to another intervention to have very effective treatments for shame and PTSD. But that's an empirical question that people can look at. It seems avoidance is underlying some of the mechanisms of change. Yes. So avoidance is a key symptom of PTSD. It's a piece of the picture. And it's not something that I personally have examined, but I know there are other people who have done lots of research on experiential avoidance as at pre-treatment and across treatment. I don't think anyone's looked at that. That would be a nice measure to look at over time to see whether changes in experiential avoidance are driving changes in PTSD.
All right, I think that was the last question we have for this Q&A session. Thank you again, Dr. Rauch, for a wonderful presentation, and thank you to our participants for attending today's training. You will receive an email shortly that includes a link to the webinar evaluation, as well as a link to the recording of this webinar. For those seeking CE credit, the post-test assessment will be distributed after these few announcements. The post-test assessment will also be included in the follow-up email for anyone interested in completing it at a later date. Thank you again, Dr. Rauch.
Thank you, and thank you everyone for your great questions. That was lots of fun. Thanks.